Just wanted to thank you for coming tonight and wanted to introduce our guest speaker. And it's Dr. and I hope I say this right, Al-Zubeidy.
Yes.
Yes. And she has quite a background. She went to medical school at Howard University. Her residency was general surgery at Howard University Hospital, and she did a fellowship at Northwestern Memorial Hospital in breast surgery. She's currently practicing breast surgery at CDH and Delnor hospitals. And tonight she's going to be discussing the surgical management of early breast cancer. And I know that some of you actually know the doctor, so I thank you so much for coming tonight. And any questions? I'm not sure if you want to have them asked at the end.
You can ask me, actually. If you have something urgent that you would want to actually ask me and I forget, definitely please feel free to interrupt me. Otherwise, we could do those at the end when we turn off the camera.
Perfect. Yes. And we do, one last thing, there are surveys in front of you, so when you're done, when the presentation is done, if you can please fill those out and just kind of leave them, you can leave them right here on this desk and I'll take them. But thank you very much for coming. Yeah, thank you.
Good evening, everyone. Thank you so much for coming on this gloomy late Monday evening, so I really appreciate you being here. I'll be talking in particular about surgical management of early breast cancer. As we can see, breast cancer can really be an extensive in terms of treatment and involves multidisciplinary teams, a lot of involvement of other teams that go beyond the scope of this discussion. But in particular, I'm going to be talking about surgical management of early breast cancer. I have no financial disclosures to share with you. I just want to show you at time of diagnosis, how many women are diagnosed with early stage of breast cancer? And first, even before that, what is early stage of breast cancer? What do we think when we say, as a breast surgeon, when we say this patient has early stage of breast cancer? And to tell you the truth, there's no clear guideline, no clear cutoff, but generally a stage 0, stage 1, and a stage 2 generally are considered early stage breast cancers. Stage 3, more advanced local regional, and stage 4 is advanced metastatic breast cancer. So here this is just a survey actually from the Cancer Center to see how many patients are diagnosed with early stage of breast cancer. So women who have screen detected, so they're getting their annual mammogram, about 60% of them have a stage 1 breast cancer. That makes sense. These are the women who are coming annually to have their mammogram. About 20% has stage 2. So by definition, we have about 80% stage 1 breast cancer. These are the women who are coming with a screen detected. Now, women who are going to their primary care with a lump, as you see, they're more likely to have actually stage 2, stage 3, and 4 combined. So there's still about 20-25% have a stage 1, but about 25% have a stage 2, about 10 to 20% have stage 3. And then the really dark purple is unknown, and we don't, per this study, they have not reported on it. And some women who come to the emergency room with a lump, clearly a lot more stage 3 and stage 4. And then the inpatient, these are the consultations that we get. The patient is seen in the hospital for something else, and then they were noted to have a breast lump. As you see, they're all over, but definitely much higher stage 2 and stage 3. It's really important to detect. The whole idea of our screening program is to detect these early breast cancers, because as you see on the next slide, the survival, the 5-year survival is significantly different. We have definitely made a survival benefit. We made women live longer as a result of our screening program. So for those who believe mammography does not work, it definitely worked, because as you see for stage 0 and stage 1, we are achieving almost 100% disease-free survival. So this is very important. Disease-free. These are women living free of the cancer. They may die of other causes, but not due to the breast cancers. So early stage of breast cancer certainly saves lives, both in men and in women. And then at 10 years survival, you can see stage 1 is still pretty high in the upper 90s, really 97, 98%. Stage 2, 87, 88%. And then stage 3 is at 70, 72%. I think we have another, yeah. So again, Early detection is key. These women are living longer, not just in the short term, the 5-year, but also on the long term. When we have a patient diagnosed with a breast cancer, our goal is to eliminate the breast cancer, eradicate it, and then hopefully reduce the chances of this cancer either coming back in the same breast or eliminate, hopefully, or reduce significantly a new breast cancer developing either in that same breast or in the opposite breast. So we have an eradication goal, and we have a reduction in either a recurrence or a second primary breast cancer. So these are our goals. As you know, treatment of breast cancer is definitely multidisciplinary. It involves 20 to 30 people on average, actually, to treat a patient with a breast cancer. And it involves a local treatment and a systemic treatment. A local treatment, definitely surgery is at the forefront, followed possibly by radiation, especially when a patient has lumpectomy. And then the body, systemically, how do we, remember those stages I told you, how do we improve survival? So this systemic therapy that I will not be discussing on today, it's certainly a key important that have led to the improved survival. That's hormonal endocrine therapy, chemotherapy when indicated, and targeted therapy, where a chemotherapy is used in combination with either immunotherapy or some other mechanism that targets this cytotoxic drugs do. That's something I will not be talking about because it involves a totally different and complicated discussion, but I do want you to be aware of that treatment of even early breast cancers involves multiple teams. I will be in particular discussing the surgical aspect. Now, in terms of surgery, we treat the breast and we treat the axilla. Sometimes, especially in stage 0 breast cancer, we don't need to worry about the axilla. Axilla, think of it as the gateway for cancer, for breast cancer, to spread outside the breast. When is that indicated to be assessed? When we have an invasive breast cancer. So this is not ductal carcinoma in situ or cancer within the duct. This is a cancer that have already left the duct, that is no longer contained within the confined milk tubes. And these are the patients that need to have at least an assessment of the axilla. So axilla is almost always assessed with the breast when we have an invasive cancer. The breast is treated surgically with a lumpectomy or a mastectomy, and I will go over these two, and that's really the main talk of today. And then the axilla, either we will assess it simply by removing a few lymph nodes, what we call the sentinel lymph nodes, or these are the gateway for the cancer to come to, and they are the ones that need to be looked at by the pathologist. If they are negative of cancer, then we can say with a 90 to a 95% accuracy or sensitivity that the cancer has not left the breast. If the lymph nodes are involved, more than 2, that means a 3 or above, we say the axilla is burdened by cancer and should be assessed or at least looked at by removal of level 1 and level 2, where we do a dissection. That involves anywhere between 10 and 27 to 30 lymph nodes being reported to be removed during a dissection. We do not do axillary lymph node dissection as much as we used to. Remember back in the treatment of early breast cancers, even back in the 70s and 80s, every woman with a breast cancer was having an axillary dissection. We now understand that there's no benefit to doing an axillary dissection when we have a contained cancer within the breast. But sometimes we still do that when we say the axilla overburdened with cancer, that we cannot rely on systemic treatment alone and radiation to eradicate the cancer. Breast conservation is really lumpectomy with radiation. That's what really is breast conservation. So just for definition. And when we say a patient is a good candidate for breast conservation, what we're really asking ourselves as surgeon and as patients is the following. Can we achieve oncological safety? Are we able to get all the cancer out and a normal, good, negative margin around it to say for sure, as far as we can tell, the cancer is all out? And are we able to give radiation to this patient to prevent or to reduce the recurrence or the chances of this cancer coming back? And by doing so, are we leaving the patient with an acceptable breast and acceptable cosmetically for her to provide a good symmetry and a good self-image. These two are important, and they are just as important. Certainly cosmesis wasn't as important before, but now we consider it just as important as the surgical oncology aspect. Now, some of the contraindications to breast conservation, as you can imagine, is patients who cannot receive radiation. So that's early pregnancy, first and second trimester, where if we do surgery with a lumpectomy, we cannot do radiation. Patients who have had a previous radiation to the chest, that's a relative contraindication. Now we're pushing it further and further, but certainly it's not easy for us to say this patient can receive further radiation if they've had radiation either with a previous breast cancer or had a non-Hodgkin's lymphoma in the past and received radiation for the lymphoma. Again, that takes them out of the ability to do a breast conservation. And what about patients who have had collagen vascular disease like scleroderma and lupus? Again, there's some contraindication for the addition of further radiation to that structure, to the body structures. And then in terms of cosmesis, are we dealing with a larger tumor that if we remove it, we're going to create a pretty cosmetically displeasing breast? We may be able to achieve the negative margin, but we're going to leave a woman not much of a breast, but more of a deformed, asymmetric reminder of her treatment. That's certainly something that is displeasing and not something that I would recommend for that patient. So large tumor to breast ratio is key. And then tumors that are within the center of the breast, right under the areola and the nipple. Again, if we remove that entire region to eradicate it and achieve the negative margin, we're going to leave her with asymmetric, this is called central lumpectomy, we're going to leave her again with a defective asymmetric breast. So location is key, size is key, and are we able to achieve an oncological safety of this tumor? How efficacious is a breast conservation? This is a question certainly that for now we don't even ask ourselves, but really breast cancer treatments have been going on since the 1760s. So it's been a long time that we've been doing surgeries on the breast. And for many centuries, and especially within this past century, for many decades, we were doing mastectomies for breast cancer. That was not a question. So lumpectomy really didn't become a big thing until the 1960s with the addition of radiation, in particular 1961 and 62, really when a lumpectomy and a breast conservation became a big deal, and it became the main treatment for early breast cancer. So how efficacious is it? Are we really eradicating the tumor when we do this? The big trial, there were multiple big trials, the National Surgical Adjuvant Bowel and Breast Projects, series of projects. Here I just mentioned the B06 trial. This particular trial actually randomized women into 3 arms. One arm got the standard modified radical mastectomy, where the entire breast, the skin tissue were removed. The second arm got a lumpectomy only, with negative margin. And the third arm is lumpectomy with the addition of radiation. These women were followed for about 25 years, so this is considered a long-term follow-up. And then the results were actually fascinating. The group that had the mastectomy had a recurrence of about 2%. That's not surprising, given that the majority of the breast tissue has been removed. The group that received lumpectomy with no radiation had about 39% recurrence. This is negative margin achieved. And then the group that received radiation after lumpectomy had about 14% local recurrence at 25 years. So we certainly see that even with negative margin, using lumpectomy alone didn't really give us a good recurrence score. We still almost half of these women recurred within 25 years. Now, what about the survival? I did not include it. The survival of this, at least for the short term, the group that had the same survival were the mastectomy and the lumpectomy with radiation. These women had almost equivalent survival at 20 years. Not surprising, I'll share several trials that actually showed these results. So the bottom line, the conclusion of this big study was lumpectomy with radiation with negative margin gave us pretty low recurrence, although higher than a mastectomy, and a survival that is pretty much equivalent as the mastectomy. And also, it did mention and prove to us that radiation is necessary in the vast majority of these women to have these acceptable low recurrences. Otherwise, almost half of these women will recur if we follow them long enough. This is from the New England Journal of Medicine in 2001, looked at women from the 1973 to 1980. About 700 women had really small tumors, so T1, that's 2 centimeter or less in size. Some of them had lymph node involvement, and the one that had lymph node involvement after 1976 all received chemotherapy, as it was the standard in the late 70s. CMF was the chemotherapy. And 2 arms, breast conservation again, versus mastectomy. The mastectomy here says radical mastectomy, but in reality it was actually modified radical mastectomy. Skin, breast out, not the muscles. Skin and the breast out. And they followed them for 20 years. And as you can see, the mastectomy group, recurrence was about 2%. The breast conservation has about 8 to 10% recurrence. This is recurrence. On the other hand, if you look, sorry, my pointer doesn't really have a good light, but the distant metastasis is what I really want you to pay attention to. That means metastatic cancers, cancer in a place other than the breast and the axilla. 24% in the mastectomy, 23.3% in the lumpectomy, almost the same. And the p-value, the statistical significance, did not reach. That means that if there is any small difference, it's really due to chance and not due to surgery. So essentially, these women had the same rate of distant metastasis. What it's really saying that distant metastasis or cancer coming back somewhere else is from a few cancer cells that have already escaped to the breast, possibly at the time of diagnosis. And so what we do with the breast is not going to reduce necessarily that risk, as we can clearly see in these 2 studies over 20 years. So metastasis is essentially the same. And then if we looked at the survival, these are the graph of the survival, both the groups, you can't really tell a significant difference in terms of lumpectomy versus a mastectomy. The dark line is the mastectomy, the faint line is the lumpectomy, and you see that at 20 years, they almost have the same survival. About somewhere between 67-68% were alive at 20 years. Both the groups almost equivalent. And then here, I just summarized all of these, some of the big trials. There are a lot more trials, but the big trials here, one of them that actually, this is done in Europe, the European Organization for Research and Treatment of Cancers. This is a Danish trial, an Italian trial, an American trial, an American trial. Many patients are included. And again, local recurrence in the lumpectomy is higher than the mastectomy. In most of these trials, the survival right here is almost equivalent in both groups, almost. And these are the follow-up years. That means how long did we, the EORTC is one of the big ones that we use. Again, 20% recurrence in the lumpectomy compared with the 12% in the mastectomy, pretty high actually. And the survival is almost the same, and they followed these patients for about 10 years. This NSABP, about 1,200, again showed similar results. Survival almost equivalent, about 60% were alive at 15 years. No significant difference between the lumpectomy and the mastectomy. This is a case study of about 7,500 women with a breast cancer. Again, some received breast conservation, lumpectomy, and radiation. Others received mastectomy. They were followed for 5 years and 10 years, and they reported their outcomes. And this is interesting to me because the group actually that did better was the lumpectomy, and the radiation did better than the mastectomy. Because if we look at the recurrence, 3% for the lumpectomy at 5 years compared with 5%, and at 10 years, 8% compared with the 12%. So according to this study, the local recurrence was higher in the mastectomy group than actually the lumpectomy and radiation, which is interesting. Is radiation doing something as to killing abnormal cells? And also, it's asking us, are they leaving thick flaps in the mastectomy that actually are now since these patients are not getting annual mammograms, maybe we have a delayed in diagnosis by the time we are feeling it. So certainly raising some questions. And then in terms of survival, overall survival, as you can see, the lumpectomy is doing better than the mastectomy. So this is questionable and interesting, but it definitely raised some important points that I wanted to bring here. Radical surgeries are not translating into better outcome. Bigger surgeries does not translate into a better outcome for patients. And then here in the same trial, in the same study, what was interesting is what were the risk factors that led to higher recurrence? Younger age. Certainly younger age did slightly higher recurrence than older age. Older. Bigger tumors, T2, lymph node involvements had higher risk for recurrence, and also the mastectomy. Interesting. Now, did women who have mastectomy, did they have to start with bigger cancers, bigger tumors, more aggressive types? Did they have family history? So these other factors were not answered by this study, but it makes us think, why is the lumpectomy group is doing actually better? And this is a large number of patients, 7,500. Now, for the sake of time, I will skip to the mastectomy. So I keep talking about mastectomy. I just wanted to illustrate the 3 different types of mastectomy that we use now. A modified radical mastectomy, or to start with, if we say total mastectomy, what I'm really saying is I'm removing everything within the dotted lines. That's the breast, the nipple, and I'm conserving only small amount of skin so that I can close the chest wall. A modified radical mastectomy is doing all of that and also removing level 1 and level 2 of the axillary lymph nodes. When I believe that the lymph nodes have significant cancer, more than three or more lymph nodes that have cancer, I may consider doing a modified radical mastectomy if the patient already wants a mastectomy. So modified mean a mastectomy plus level 1 and level 2 axillary dissection. We can actually now do, pretty safely so, total mastectomy, but actually conserve the skin so that these patients have reconstruction, where the plastic surgeon comes in after I do the mastectomy and then do reconstruction, either autologous reconstruction, where part of the body is used to rebuild the breast, or an implant-based reconstruction. We can also now, in selected patients, preserve the nipple and the areola. Now, interesting about the nipple, the ducts, the milk ducts that come into the nipple, actually, they come right to the tip of the nipple. So the nipple always contains a small stump of duct. Traditionally, we thought that increases the risk of future cancers, future breast cancers, but studies actually show, at least in the short and intermediate term, there was no difference in recurrence. The long-term new data is just coming out that actually on a long follow-up, we think nipple sparing may have a slight increase in recurrence compared with the skin sparing. We have different techniques to do skin-sparing mastectomies. This is just really for you to show how we do it. We could do it peri-areolar, we could do it elliptical, but skin-sparing means we're removing the nipple and the areola, all the breast tissue from the clavicle to the inframammary line, from the sternum all the way to the end of the chest wall, and we're preserving the skin for the plastic reconstructive part. With the nipple sparing, we're doing a little bit more, it's more difficult to do, but we can hide the line, the incision in the inframammary. We can doing around the areola and extend it down or extend it inferiorly. So there are different techniques to do that, but the nipple and the areola is preserved in the vast majority. Is there a benefit to doing a mastectomy? So remember those patients I told you, the ones who cannot receive radiation, the early pregnancy, certainly the patients with scleroderma or lupus or other disorders, patients who had a previous radiation due to Hodgkin's lymphoma when they were teenagers. These are definitely patients that would fit the criteria for a mastectomy because a breast conservation is contraindicated. So when there's a contraindication, certainly there's a benefit to a mastectomy. Also for women who have other risk factors, a significant family history of breast cancer, a BRCA1 or 2 mutations where they have an additional 30 to 40% risk of additional breast cancers, and women who have multiple previous abnormal breast biopsies. We have to remember that there is really no disease-free survival and overall survival difference in the vast majority, about 90% of women with diagnosed breast cancer. Now, what about contralateral breast cancer? I've been diagnosed with one-side breast cancer. What's my chance of getting an opposite breast cancer? The risk, actually, we've been looking at this data, and at 10-year cumulative risk, we believe there's about 5% risk that I would get a contralateral breast cancer. Well, if I do a mastectomy on the opposite side, I'm removing about 90% of the breast tissue, so I'm going 90% of 5%. Well, that's not a significant reduction, right? I'm going to about 1%. And what's the likelihood I'm going to die of an opposite breast cancer? That's really less than 1%. So the benefit of doing a contralateral breast cancer is very low. Because to start with, we have a low risk. I'm assuming I'm starting with an average risk for future breast. I'm not talking about a BRCA patient here. I'm talking about an average risk woman diagnosed with a breast cancer, one-sided. Her risk at 10 years for an additional breast cancer is about 5%. So if I'm doing a contralateral breast cancer, I am getting a 90% reduction of a 5%. Well, that's not a significant reduction. It is a reduction, but we're starting with a small number. So these women are not likely to benefit. And usually when they die, they're not dying of a contralateral breast cancer. They're dying of metastatic breast cancer from the initial diagnosed cancer, or they're dying of other comorbidities. So again, survival, that's why we don't see a significant survival difference between the groups. What about high-risk patients, the BRCA that I talked about? Well, a breast cancer in a patient who already has a BRCA has about 20 to 40% chance of another breast cancer developing over the next 20 years. That's a high number because that risk of a genetic mutation, BRCA1 carries about 80% risk of a breast cancer. If the woman already got diagnosed with a breast cancer, she has about 2 to 4% annual risk of a second to primary breast cancer. So over 20 years, at 2% certainly will add up. At 10 years is at 20 to 40%, and if you follow them longer, you're going to find a significant number. So these patients are likely to benefit from a contralateral mastectomy and a bilateral, and we can show a survival difference. Because again, 20% of breast cancers may end up being in stage 4, and if you calculate these numbers, we can actually show a survival difference. What about patients who had for a Hodgkin's lymphoma radiation during their teenagers above the diaphragm? Well, they also have an annual risk of a 3 to 4% of a breast cancer. So these patients are also considered high risk simply because of the radiation. So if there is a risk factor, we see there is a difference with a mastectomy in terms of survival and in terms of recurrence. Other than these groups, we don't actually show any difference. What about women who are diagnosed with aggressive biology tumors, the triple negative, the HER2 positive, the lymph node involvements? Is a more aggressive biology translates into a more aggressive surgery needed. And we've been following. And if you look at the studies, we show no difference in survival and no difference in recurrence. So triple negative breast cancers and HER2 positive tumors surgically do not necessitate a mastectomy. And in fact, doing a mastectomy, again, shows no difference in survival. What this biology is telling us, we need to consider systemic therapy, chemotherapy, potentially immunotherapy for these patients. That's the treatment that makes the survival difference, not a more aggressive surgery. Same thing with lymph node involvements. Once we have the lymph nodes involved with cancer, what we do with the breast does not improve a survival, whether we do a lumpectomy or a mastectomy. So having 3 lymph nodes with a breast cancer does not really mean we need to do a mastectomy, and if we do, we still have not really made a survival difference. We're not going to live longer because what we do with the breast is not going to influence the long-term impact. Nonetheless, despite what we've been saying about breast cancer, there's certainly a rise. This is disturbing a little bit for us in surgical oncology world. We see a rise in mastectomy. And this is really just in 2012. But right now, we believe that about 33% of breast cancer patients are resulting in bilateral mastectomies. So this is the blue. The blue is a bilateral or double mastectomy. This is to 2012. We find about 25% of women at diagnosis undergo a bilateral mastectomy. Now we believe it's actually higher than 1/3 of women. And who is likely to choose it? Young, educated, white, Caucasian women. Those are the ones more likely. And again, fear, anxiety is a big factor. Younger age is a big factor. Most of these are young mothers who just diagnosed, so definitely anxiety. And with bilateral mastectomy, there is something we call anticipated regret. Anticipated regret is, I've been diagnosed today. If I don't remove my breast, in 5 years I'm going to have breast cancer, and I wish I had removed both of them. Anticipated regret. It's going to happen. It's inevitable. Let me remove both of them now. That's a major drive for this rising trend. We overestimate, or patients tend to overestimate the benefit of a mastectomy. If I do a mastectomy, I'm going to live longer. If I have a mastectomy, I'm not going to have chemotherapy. I will never need radiation. I will never have to worry about a breast cancer. Certainly myths. All of them are myths. As we see, the aggressive surgeries do not translate into better survival. And if chemo is needed, it has nothing to do with what we do with the breast. Chemo is a systemic treatment for cancers that are more likely or has a higher chance probability of a distant metastasis. What we do with the breast does not influence that. What are the costs of the mastectomy? So what's the big deal? So what if women have mastectomy? Well, this is just a little Cochrane review that actually looked at 15,000 women who underwent risk reduction mastectomy. So they started with a breast cancer and had bilateral to reduce. And they followed them for many years, and I just broke it down. I just wanted to bring your attention to this lower bullet. 4% of women who had mastectomy without reconstruction required a return to the operating room unanticipated for a complication. And about 64% of women who had reconstruction required a return to the operating room for unanticipated surgery. This is not a surgery related to their reconstruction. This is not for an exchange of an expander. This is due to a hematoma, an infection that developed that needed to be drained. This is due to a rupture. They followed these women for about 10 years. Rupture was a big deal. Contractures, pain. So there are some complications that led to a need for further surgery. This is more than half. This is significant. And many women do not anticipate additional need for surgeries. Complication risk that we say about 15 to 20%, these are significant complication risk. And just to bring your attention here, this is certainly a small, to the anaplastic large cell lymphomas that have gaining a lot of media attention recently, that's been linked to implant ruptured. More than likely, silicone, although it can happen with saline, a rupture of the implant over time have led to few patients, only 467 patients have been reported to the FDA, leading to this anaplastic large cell lymphomas related to implants. Well, because of that, the FDA now recommends an MRI for 3 years, and then every 2 years thereafter for any woman who has at least a non-smooth, contextured implant. That's something that many women do not anticipate. They think if they have a mastectomy, I will not need any further imaging. Well, this is certainly a concern because of the impact of this complication. And about 17 to 20% have a rupture rate. That number has actually been going down. And on the next slide, this is an article, a trial actually, been published by the Journal of Plastic Surgery, and it really followed women from the 1970s to the 2015, over 10,000 women who had nipple-sparing mastectomy, of course, with reconstruction. And I just wanted to bring that complication risk here, about 22%, your attention to this, about almost 1/4 of these women, 1/5 to 1/4, had a complication. Most of the complication, though, I have to say, were before 2013. Because after 2013, we changed. The FDA had certainly put more stringent guidelines on these implants. So there's less failure rate. Silicone implants were the way to go in the 1990s and 1980s. Then they took them off of the market because of significant rupture. Then we went to saline until really about 2008, and then now we have a new generation, about 5 generations of silicone, more safer implants, but nonetheless, we had high complications before 2013. Now it's a little bit less. Nonetheless, it is significant. And this is, again, just another study, about 700 women, explantations about 4%, return to the OR about 9% in women who have bilateral mastectomy with reconstruction. So this is not a benign or small surgery. That's all what I want to say. It's important when an important surgery, it's an important aspect to treat for women who are high risk, but it certainly comes in at a high cost. And then finally, this is really not something that gaining a lot of attention, but about 1/4 to 1/5 of women have certainly reported after mastectomy body appearance, decrease in body appearance satisfaction, a loss of feeling of femininity, certainly sexual dysfunction, phantom pain in about 1/3 of these women, and insensate. I mean, when I'm removing the breast, there are not many nerves left, really. There's tiny twigs of nerves left. So most of that skin is insensate, right? So that's not getting a lot of attention, but it's really important, at least on the long-term follow-up for these patients. We'll go back just a little bit for personal risk factors for future breast cancer. Again, this is important because most women are going into this decision thinking of, they have full faith, the vast majority has full faith in us eradicating the tumor, but what can I do to reduce my recurrence risk? That's really the big drive for the mastectomy, at least that's what we believe. And two points here, a recurrence risk, that means the same cancer coming back in the same region of the breast at about 10 to 15 years. Well, that is what we call a recurrence. About 20% of breast cancer will recur if we do nothing else but surgery. A second primary is either the same breast, is either the same cancer or a different biological cancer will show up either in the same breast or in the opposite breast. This is totally unrelated to the first breast cancer. So a recurrence is decreased if we get negative margins, if we use radiation, if we use endocrine therapy. Radiation is actually bringing that risk down by about 30 to 60%. Nonetheless, about 20% of women who meet the guidelines for radiation do not go with the radiation. Again, fear of radiation. It's important, really, radiation here is for a recurrence risk. What about the second primary risk? That's family history, genetics, estrogen exposure, diet, exercise. That really drives that formula. This is very small a study, but I really liked it, about how good women are at estimating their risk for future breast cancer. Well, the low and average risk women tend to overestimate, almost double overestimate their risk, and the women at high risk tend to underestimate. So essentially, we're not good at estimating. And then here, just another study. This is actually a bigger study, 750 women on primary care. They asked them about what do they think their risk of breast cancer, and then they've done the Gale model as their clinical motive, and what they found, about 80% of women overestimated by 50%, about 1/3 overestimated by 5-fold, and only 7% underestimated. So we tend to overestimate. Overestimation is really what's leading to all the rise of the mastectomy. What about secondary breast cancer, that second primary? The different risk factors that led to the initial breast cancer are here at play when it increases the risk for second primary. So family history is a big part. Hormonal exposure, hormonal replacements, high BMI, high estrogen exposure because of early menarche, late menopause, nulliparity, right? All the factors that increases the estrogen. Estrogen is the big drive. It's the main drive that leads to breast cancer. That's why we women have much higher risk of breast cancer than men. Estrogen is a big drive. Pathologic factors, previous abnormal biopsies, a history of breast cancer on one side certainly increases the risk for a second primary somewhere else in the breast or in the opposite breast. So these risk factors really are the main drive for a second primary. And then who needs genetic testing? We keep talking about genetics. Who needs a genetic testing? This is the NCCN guideline for 2019. A breast cancer in high-risk ethnicities like an Ashkenazi Jewish heritage. A triple breast cancer, that, again, aggressive biology in younger age, at the age of 60 or less. Any breast cancer at 50 or younger. A family history of breast, ovarian, pancreatic, metastatic prostate. There is a linkage in between genes. So these patients or these individuals meet the criteria and should undergo genetic testing. But remember, only 5 to 10% of breast cancers are genetically induced, or there's a gene that we can lead to. And here I listed from the NCCN several genes that we look at. The ones that we have a clearer, I don't want to say clear, but a clearer approach, the BRCA1 and BRCA2. These are 2 of the 4 that we know what to do. If I have a patient with these mutations, more than likely I'm going to have a discussion about a bilateral mastectomy because of a high breast cancer risk. These are other genes, but I really don't know what to do with it. All what I say is you're at increased risk. We need to put you on a high-risk surveillance with MRI and mammogram, but there's no evidence that a mastectomy will help in survival or recurrence. The other 2 genes I told you is the P10, this is Cowden syndrome, and TP53, Li-Fraumeni syndrome. These are the other 2 that we know are also significantly high risk, and we have some early studies that show a survival benefit when we do bilateral mastectomy. Those are the only 4 that we have action plan, surgical action plan for. The rest, we put them in a high surveillance. And then here, this is just to summarize kind of everything. What we choose, more importantly, when we treat breast cancer, what is our oncological outcomes? Are we able to achieve eradication of breast cancer? Are we improving local control and overall survival? Is the patient happy with their surgical outcome? Do they feel back to normal, to their psychosocial well-being prior to the procedures? What kind of complications did they develop? What is the impact of these complications on their life? And overall, what's the cost? Just to let you know, mastectomy, as you can imagine, is one-sided mastectomy is actually 20 times more expensive than a breast lumpectomy with radiation. Breast lumpectomy with radiation is coming up between $80,000 to $90,000 for the treatment. A mastectomy is somewhere between $125,000 to $155,000 according to the SEER Medicaid and Medicare cost. And then in conclusion, I do want to say that women tend to overestimate their personal risk for recurrence and for second primary. In each individual patient should be analyzed regarding the risk of breast cancers, both in a recurrence as well as in a second primary. It is very crucial that women and their clinicians understand the risk for each individual, so individualize the treatment for that particular patient based on their family history. And then we should definitely give consideration to breast conservation first. If they are a candidate for it, recommend it. If not, then consider the mastectomy. A patient's decision is certainly important, but I believe many patients go into this without knowing the full picture and they are not well informed. Risk-reducing mastectomy is effective in high-risk group, but really no survival difference in the vast majority of patients at diagnosis. We have definitely improved systemic therapy, and that's the treatment that made the most overall survival significance. And a mastectomy is not a complete reduction or not a complete elimination of a future breast cancer. As we have seen, about 4 to 10% of breast cancers do develop within a mastectomy flap. These are some of my references, and I'm sorry to bore you to death with a long talk, but I really appreciate it.